So I'm going to talk to you for the next 20 minutes or so about mechanical ventilation in the kidney. And when I talk about mechanical ventilation, much of my talk is going to focus on ARDS because many of our studies of mechanical ventilation occur in the ARDS population. You'll recall that this is the leading cause of hypoxemic respiratory failure in our critically ill patients, and that we say that ARDS develops following certain clinical conditions. These are typically divided into causes of direct lung injury and indirect lung injury. Mortality from this condition remains high at 30 to 40%, not as high as AKI in its most severe forms. And no specific therapies are available. We really rely on ventilator and fluid management strategies to treat ARDS. Now, that being said, what seems to be good for ARDS may be good for all patients with respiratory failure, and this has been shown in a couple of recent studies. So, as you know, one of the mainstays of our interventions for patients with ARDS is low tidal volume ventilation. And in this analysis, looking at patients without the acute respiratory distress syndrome, in a meta-analysis of 20 articles that examined over 2,800 participants, a low tidal volume ventilation strategy in participants without ARDS was also associated with a lower risk of developing ARDS, with a risk ratio of 0.33, a very strong protective effect, and also with a lower risk of death with a risk ratio for mortality of 0.64. And in another very similar study, Futier and colleagues performed a clinical trial where they examined patients undergoing elective major abdominal surgery at high risk of postoperative pulmonary complications. And they examined the relationship of lung protective ventilation with outcomes, with a composite outcome of pneumonia, need for invasive, non-invasive ventilation, sepsis, and death, and showed that, again, the lung protective ventilation strategy was beneficial in this patient population. So more and more, we think that strategies with the mechanical ventilator and that we use in patients with ARDS are good for all patients who are mechanically ventilated. So just briefly, a couple of slides on ARDS. You'll recall that ARDS was defined for approximately 20 years using the American-European consensus definition. This divided the entity of ARDS and acute lung injury by PaO2 to FiO2 ratio as the presence of bilateral infiltrates without left atrial hypertension, and then ARDS was the more severe subcategory here. And you can see here a representative chest X-ray showing those bilateral infiltrates. More recently, the ARDS community has turned to the Berlin definition to define ARDS, and this is really just a modification of the AECC definition. It preserves the important central features of the prior definition with the PF ratio less than 300 and the presence of bilateral radiographic opacities that are not primarily due to heart failure. However, it eliminates the term acute lung injury and rather uses the classification scheme of mild, moderate to severe, akin stage 1, 2, and 3 AKI, defined based on the PaO2 to FiO2 ratio, and importantly specifies that patients with ARDS must receive positive pressure ventilation with a positive end expiratory pressure of greater than 5 to define the condition. The definition also makes some clarifications from the prior AECC definition, emphasizing that ARDS is an acute condition, recommending that it's important to assess for a known risk factor for ARDS, and if one is not present, assessing cardiac function, recognizing that many of our patients have heart failure. And I should comment that several additional features were considered for inclusion in this definition, but were ultimately discarded as they did not add predictive or prognostic value. So turning now to the question of what are the effects of mechanical ventilation and perhaps ARDS on the kidney, there are a number of potential mechanisms by which ARDS may affect the kidney and cause downstream epithelial injury and downregulation of important channels in the kidney for water handling. And we'll review these in turn. These may include hemodynamic effects, effects on cytokine, and the impact of endothelial injury in this condition. So first, what are the hemodynamic effects of positive pressure ventilation? We know that there are three entities that can occur in this setting. These include decreased venous return due to increased intrathoracic and right atrial pressure. And this is exacerbated, we know, by common conditions in our critically ill patients, including intravascular volume depletion and higher airway pressures, why it's critically important for us to define the appropriate volume resuscitation in these patients. In addition to this mechanism of decreased venous return, we can see decreased right ventricular output due to increased pulmonary vascular resistance. And the increase in pulmonary vascular resistance may also lead to decreased left ventricular output due to decreased left ventricular filling. Now, I should note that these hemodynamic effects we know depending on both lung and chest wall compliance. So the stiffer the lung or the stiffer the chest wall, the less likely you are to see large hemodynamic effect. In a normal lung, you are more likely to see larger hemodynamic effects. In addition to these hemodynamic effects, we know that there are neurohormonal effects that may further impact GFR and renal blood flow. And these include non-osmotic ADH release, increased sympathetic tone leading to activation of the renin-angiotensin axis, as well as suppression of ANP. So turning now to the question of cytokines, there have been a number of cytokines that have been shown to be affected by acute lung injury. And so this is a study from Slutsky and colleagues examining injurious ventilation strategies in a rabbit model of lung injury. And this slide shows you that after 4 to 8 hours of injurious ventilation, a number of cytokines are elevated in these rats after injurious ventilation, including MCP1 and IL-8. And this results in tissue injury in the form of elevated LDH, as well as elevated serum creatinine after 8 hours of injurious ventilation. And if you look at the kidney itself, you can see that there, in fact, that there is significantly more apoptosis in the kidney. This is tunnel staining, showing you that in the uninjured kidney, in the kidney of an animal undergoing the non-injurious ventilation strategy, the percentage of tunnel positive or apoptotic cells is quite low, and it's significantly increased in the animal that undergoes the injurious ventilation strategy. And I think perhaps most striking in this analysis, these authors demonstrated that plasma from the animals that were treated with the injurious ventilation strategy could in fact induce this apoptosis. So when cells were treated with this plasma, the rate of apoptosis was markedly increased. So again, perhaps what is good for the lung is good for the kidney. And so now I'm going to show you data looking at similar cytokines in human studies of ARDS. So this is data from the pivotal ARDS network study, the low tidal volume ventilation strategy, to remind you that that ventilation strategy was associated with a very significant decrease in mortality from approximately 40% to approximately 32%. And at the same time, that lung protective ventilation strategy was associated with a very significant decrease in plasma IL-6 over the first 3 study days. So let's look at AKI in this study. So how is AKI defined for the study? For the purposes of the original analysis, the ARDS network examined organ failure-free days defined by the Brussels sepsis criteria. And for that analysis, renal failure was defined simply as a serum creatinine of greater than 2. Those who received low tidal volume ventilation had more renal failure-free days in that analysis, with more renal failure-free days being a beneficial outcome, 20 versus 18 with a very significant p-value. There was no difference in the rate of AKI between the 2 treatment arms. But turning to the kidney in more detail, I can tell you that when we use more conventional, this is a rifle definition of AKI because that was the most contemporaneous definition at the time we did this analysis. The rate of AKI was very significant in this population. Almost 25% of subjects developed AKI. And in multivariable analysis, we were able to demonstrate that elevated levels of IL-6 were associated with an increased risk of acute kidney injury, along with a number of other plasma cytokines. So implicating that perhaps IL-6 is one of the mechanisms by which this injurious ventilation strategy may impact AKI. This has been very nicely shown in similar analyses by Marco Ranieri. This is data, again, examining bronchoalveolar lavage fluid levels of inflammatory cytokines and demonstrating that those levels go down in patients treated with a lung protective strategy and are unchanged or go up slightly in patients treated with a control ventilation strategy. And in the same analysis, very similar findings with plasma cytokines. So turning to other mediators that may affect the relationship of AKI, to AKI, there's been a lot of interest in nitric oxide, and Joe Bonventre and his colleagues were able to show that in animals treated with an injurious ventilation strategy with a very high tidal volume, the treatment with a NOS inhibitor, LNAME, was able to aggregate both extra Evans blue dye extravascular lung water in the lung, as well as the kidney. You can see that here with the decrease in lung water with the LNAME treatment here, and in the kidney in the similar bars. And in the same analysis, they were able to show that mechanical ventilation with injurious tidal volumes was associated with AKI, defined by creatinine in those animals, attenuated by the inhibitor, and also with an increase in proteinuria that was again attenuated by the inhibitor. When they looked at more specific cytokines, they were able to demonstrate that in these animals treated with the injurious ventilation strategy, levels of VEGF were increased, as well as levels of eNOS in both the lung and the kidney. So turning to the mechanism of endothelial barrier, it has been shown that adrenomedullin, is a critical mediator of, that maintains the endothelial barrier integrity in conventional animals. And again, it's been shown that adrenomedullin may be protective against ventilator-associated AKI. So this is again using a high tidal volume ventilation strategy. This is again looking at plasma lung water, showing that plasma lung water is markedly elevated when animals are treated with a high tidal volume ventilation strategy, abrogated by treatment with adrenomedullin. At the same time, you can see that injurious tidal volume ventilation strategy is associated with rise in plasma creatinine and attenuated by the inhibitor. And at the same time, not surprisingly, that treatment with adrenomedullin is associated with reduced levels of pro-inflammatory cytokines, including IL-6 in the BAL fluid and IL-6 in the plasma fluid. So I'm going to turn for the last few minutes to just commenting on the impact of our current adjunctive care strategies for patients with ARDS and AKI. So as you know, with our low tidal volume ventilation strategy, one of the critical tenets is permissive hypercapnia. And this allows us to treat patients with low airway pressure. Specifically, our target plateau pressure is less than 30. So we reduce our standard tidal volume is a target of 6 cc's per kilo predicted body weight, but sometimes are reduced as low as 4 cc's per kilo depending on the patient's lung compliance. The target pH with this strategy is a pH of 7.3 to 7.45, but lower pHs are tolerated provided there are not hemodynamic effects. And obviously, in the situation of normal renal function, patients develop a compensatory metabolic alkalosis. So there's been a lot of interest in the effects of the hypercapnic acidosis in and of itself, and there have been a number of animal studies that have suggested that hypercapnic acidosis may in fact be cytoprotective. It's been shown in vitro studies, that inactivation of calcium channels may lead to regional vasodilation and better blood flow. There may be a reduction in cellular oxygen demand, and there may be reduced conversion of I-kappa beta to NF-kappa beta, which results in lower levels of cytokines. And it's interestingly thought that this may be due to the CO2 rather than the acidosis itself. That being said, there have been studies suggesting that in advanced sepsis, hypercapnia may enhance bacterial proliferation and thereby promote cellular injury. So there's a balance that needs to be achieved here that we don't yet understand. And the second strategy I'm going to address is the strategy of adjunctive care. For adjunctive care is the diuretic strategy that we are now commonly using in our patients with ARDS. This is just to remind you, this is the treatment strategy for the FACT trial, which is a strategy of furosemide targeting low filling pressures in patients with ARDS. This strategy resulted in an approximately even fluid balance for patients treated with the fluid conservative strategy over the first 7 days of the trial, compared to a very positive 7-liter fluid balance over the same time in patients treated with the liberal strategy, and that matched very closely to the fluid balance in patients treated in other ARDS treatment trials prior to that analysis. So this trial failed to hit on its primary endpoint of mortality, though there was a trend towards decreased mortality in patients treated in the fluid conservative arm, but did hit on the secondary endpoint, composite endpoint of ventilator-free days, which is a composite of time on the ventilator in survivors and death, with more ventilator-free days in patients in the fluid conservative arm compared to patients in the fluid liberal arm. So what were the AKI outcomes in this study? So this was the primary analysis for the study, which examined the rate of dialysis to day 60 and showed that, in fact, patients in the liberal arm had a trend towards needing more dialysis than patients in the fluid conservative arm. Unfortunately, we have no data on why patients in this study received dialysis. So we have been very interested in the impact of fluid overload on AKI ascertainment and have used this data set to do some analyses. This is just to remind you that this is really a strategy suggested by Etienne Macedo and Ravi Mehta in some analyses that they did in the Picard study, suggesting that fluid overload can lead to delayed recognition of AKI. And so we took a very similar approach to examining data from the FACT trial, and were able to define, importantly, 2 subgroups of patients whose definition for AKI changes when you adjust for fluid overload. So there are patients who become fluid overloaded who do not have AKI if you look at conventional creatinine, and do have AKI if you do adjust for creatinine. And similarly, there are patients who have AKI if you look at creatinine, but when you adjust for a very negative fluid balance, no longer have AKI. And what we showed in this analysis was that patients who had AKI had very increased rates of mortality, and lower ventilator-free days. And interestingly, that patients who had that AKI after you adjusted for fluid overload also had very adverse outcomes with higher mortality and lower ventilator-free days. And finally, in this analysis, we showed that AKI was an independent risk factor for death. This is a multivariable analysis showing you that, in particular, in that group who has AKI regardless of fluid balance, AKI is a very strong predictor of death in this population with ARDS. So turning now to sort of our treatment strategies after FACT, the FACT protocol requires every 4-hour assessments of CVP and pulmonary artery occlusion pressure with very frequent diuretic measurements. The protocol has now been simplified for our ARDS network studies to this much more simple algorithm. The original treatment algorithm had 36 treatment boxes. For patients who do not have a central venous pressure, who do not have a line to measure central venous pressure or pulmonary artery occlusion pressure, we target an even fluid balance over the first 7 days of the trial. And what I can show you here in data looking at examining patients who are now treated with this simplified FACT algorithm compared to patients treated with the FACT conservative algorithm, that in fact the rates of AKI are very similar whether or not you adjust for fluid balance, with mortality rates that are also quite similar. And I should comment that I didn't put the slide in here, but the severity of illness of these two groups is also quite similar. So finally, I'm going to end by just commenting on the reverse direction. I was tasked with discussing the effects of mechanical ventilation on the kidney, but I want to remind you that, as we've talked about today, AKI may also have many systemic effects, and that specifically that uremia may lead to in the presence of reduced GFR, may lead to decreased clearance of inflammatory mediators, including cytokines. That elevated levels of pro-inflammatory cytokines, which we know occur in the setting of AKI, may also drive injury. Furthermore, endothelial injury may be further exacerbated by volume overload and cause injury to the lung, and macrophages, we know, play an important role in the pathogenesis of ARDS and may be affected by the presence of AKI. So I'm going to stop there and summarize that over the last 20 minutes or so, I've shown you that multiple mechanisms may result in AKI after mechanical ventilation. These include hemodynamic effects of mechanical ventilation, the presence of pro-inflammatory cytokines, as well as disruption of the endothelial barrier due to disruptions in nitric oxide and other important pathways. That low tidal volume ventilation is associated with lower levels of pro-inflammatory cytokines, and this may be a mechanism by which our mechanical ventilation strategies impact our rates of AKI. And finally, that other supportive care interventions for patients with ARDS, including permissive hypercapnia and our fluid conservative management strategy, may affect AKI as well. Thank you very much for your attention.